this topic. So, last time we have discussed there are 6 functional types of eye movement, supranuclear eye movements, where there is supranuclear control over different group of eye movements, and we even discussed about the purpose of eye movements. Like there are the purpose we discussed. So one by one, I will tell you about different purposes. The first is yeah. The first is hold images of the visual world steady on the retina during brief head rotations or translation. So when suppose I'm moving my head briefly, suppose I'm moving it right or left. So during that brief rotation, to maintain the, suppose I want to keep looking at the screen and I move my head briefly to right or left, that movement is brought about by vestibulo-ocular reflex. So vestibulo-ocular reflex helps us to maintain the stability of the gaze despite of the head rotations, which are brief. Then the second purpose is hold the image of a stationary object on the fovea, minimizing ocular drifts. Suppose you are looking at the screen and you don't want to, you want to avoid the saccadic movements or microsaccades. You want to fix on the screen, then that is done by the visual fixation. The third purpose of eye movement is hold images of the visual world steady on the retina during sustained head rotation or translation. Means suppose you are translating in a train. Suppose you are sitting in a train and you are looking outside to the scenery, or you are on the platform and looking at the train. So whenever there is, you are either translating or the visual, whatever you are looking at is translating in a fixed direction. What happens is, to keep the visual world steady, there is a reflex called as optokinetic reflex. So that helps in keeping the this particular in this particular scenario, keep the visual world steady on the retina. Then next is hold the image of a small moving object. If there is a small moving target on the fovea, and if it is moving in a slow speed and it is at long distance, then what happens is slowly the eyes are able to pursue that target with the help of smooth pursuit. So the nerve itself indicates that we can smoothly pursue the target because of this smooth pursuit movement. Then the next purpose of the eye movement is bring images of objects of interest onto the fovea. Means for example, if I'm looking here and suddenly something appears in the peripheral visual field, and then if I have to look at that particular object, then I will suddenly move my eyes towards that direction. That is particularly done by the saccades. And move the eyes in opposite directions so that images of a single object are placed or held simultaneously on the fovea of each eye is brought about by vergence. For example, an object moves towards the eyes, then both the eyes will converge to look at the near approaching object. And if an object is moving far away, there is a little divergence of the eyes. That is that happens because of simultaneous contraction of the lateral rectus of both the eyes. Now, last time we discussed about how the saccadic testing is performed. Now, if you look at here, okay, the saccades are nothing but from here the eye is moving to the left, moving to the right, okay, and you can see the saccadic graph from left to right here, then it is maintained steady here, and then it goes from right to left, okay. So the stimulus is moving. You can see the green one is the stimulus, and like this one particular is there is a latency. There is a latency of milliseconds, like up to 200 milliseconds, and then there is saccade from left to right. Then there is it is maintained in that position, and then it comes. It can either come to the center or it can go to the left side. So here you can see now the subject is sitting wearing the goggles, and the this thing like is moving from one area to the another area directly. It jumps from here to here, left to right, and then jumps from right to left. Okay, so this kind of movement is called as saccadic movement, and this this is a horizontal saccade. So the cerebrum decides, we have seen last time, when and where to move, and the brainstem determines how to move the eyes with the help of the various gaze centers. Now we have also seen last time about the smooth pursuit eye movements, where you can see the object is moving, swinging from right to left, and it is not disappearing. It is smoothly moving in the screen. And if you can see here, the eyes are also smoothly tracking the object from right and left. And you can see here the graphs are recorded, smooth pursuit graphs are recorded. Okay. So this is about the horizontal smooth pursuit. Now look at the vertical smooth pursuit. The object or the object of regard is moving up and down, and the eyes are pursuing vertically. Okay, and that movement is vertical smooth pursuit, and it will give the gain, right to left gain, rightward gain, upward gain, and downward gain. It will give. In case of horizontal, it will give rightward and leftward gain, and they are falling into the normal. The precision is normal, like. So this is again regarding the vertical smooth pursuit video. The eyes are moving up and down, and you can see the graph is recorded here. Okay, the smooth pursuit graph is recorded here. Next, yes, last time we have seen the optokinetic stimulus is given. Okay, this is optokinetic stimulus. And you can see the optokinetic nystagmus, which is recorded here on the graph. And the eyes also is showing, this is a normal nystagmus. This is a physiological nystagmus you can see, which is a left beating nystagmus. Left beating nystagmus you can see when the stimulus is moving from left to right, left beating nystagmus is seen. So that was revision of the previous session. We discussed 3 testings: saccadic testing, smooth pursuit, and optokinetic. So this time we dive into the spontaneous testing, the first part. So in this, basically, when you look at the eyes of the patient, with the help of the videonystagmography, we are aiming to check for the nystagmus. But there are other things which also we can examine, that is skew deviation, which is a very important central sign, ptosis of the eyelid, like that is drooping of the eyelid, and pupillary asymmetry also is very important because it is another central sign. So main focus of spontaneous testing is to check for any nystagmus. So let us go into the details of the nystagmus. So, yeah, yes. So let us dive into the nystagmus. So before going into the nystagmus, just now I have showed 2 things, like 2 pictures, where this you can see the video nystagmography goggle. When the visor is open, okay, it is we are testing with fixation. The patient is fixating, that is, it is in light. So patient is fixating on the target, object of regard, and you can see the visor on, like that is the lid is on, and you can see me in the background. This is without fixation, and SPN in dark. This is spontaneous testing in dark. Like patients is completely cut off from the visual stimulus. And here you can see one good thing like about this picture is you can see in this photograph this area is very clear, and you can see this background. Even my face is looking blurred. This is how our peripheral vision is. Now currently you are focusing on the screen, and if you keep your focus on the screen and try to look at the objects in the periphery, they appear blurred. Okay, that is because only the screen is on the fovea and parafoveal region, and the other parts you are able to see is in the peripheral retina. So that's why my image is blurred. That is in the peripheral retina, and actually in the photographs also we can see the blurred background. So that's a peculiarity of this photograph. Regarding the nystagmus, it's very important to understand the nystagmus because that is the most crucial aspect of video oculography. That's why even it is named as videonystagmography instead of video oculography. Ideally the name should be video oculography because it helps to check all types of eye movements, not only nystagmus, but because we have more emphasis on the nystagmus, so it's very important to understand what is nystagmus, what are the attributes of nystagmus, and why we are trying to look at the nystagmus. So let us go into that. So if we look at the nystagmus, it is involuntary movement. It is not a voluntary movement. Second, it is a rapid movement. Third is it is rhythmic. There is a rhythm involved in it, and it is oscillatory movement. These are oscillations, like to and fro oscillations, and it must have at least one slow phase. Either it can have one slow phase or it can have two slow phases. If it has
आज देखो
both the
बलि
fast
दिया है
phases,
पॉइंट का
it is
पानी
not a
पानी
nystagmus.
बहन
It
चो
is
तब कम दे रहा है
nystagmus
20 का
light movement, which is nothing but some type of saccade. We are going to see that. So nystagmus is underutilized in the diagnosis. It is used only 5% of the times in the emergency rooms, and many a times whenever it is labeled, it is labeled as nystagmus is present. But it is very important to characterize
प्लस
the
कलर
type
कर
of
लिया टिकट
nystagmus that gives the
कितने पड़े
diagnosis.
100
Why
रुपये
we
दे
are
दिया
trying to do video
क्यों कर दिया
nystagmography or video oculography is basically to know what is the type of nystagmus, what are its features, how it is variating with the gaze position, what is the variation without fixation. So we are trying to look into the eyes very in detail. Video nystagmography, I would say, is nothing but looking at eyes under a microscope. We are trying to categorize each and every eye movement so that we get the diagnosis, we get the localization. So nystagmus is a common diagnostic challenge. Causes of nystagmus can be physiological, as we have seen, like optokinetic nystagmus, or it can be life-threatening. For example, like some types of nystagmus, like
क्या
Crohn's
कितने
nystagmus,
को
rebound nystagmus, which is of cerebellar pathology, downbeat nystagmus.
बम कर दिया
And most important thing is the differentiation between central and peripheral variety of nystagmus. If you look at the most common type of nystagmus is vestibular. But of course, there are central vestibular type of nystagmus, and there are other types of other varieties of nystagmus. And one of the major area of concern is, am I missing a central pathology when I look at nystagmus? The most common type of nystagmus is peripheral, but of course, central nystagmus is very important to identify central nystagmus. And if nystagmus is present, it is of central variety, and MRI comes normal, then it creates a lot of diagnostic confusion and anxiety. So let us try to simplify this topic. So I'm going to cover the basics, and there are 47 different types of nystagmus. So we are not going to go into the details. I'm going to just cover the basics for the audiologists who are attending the webinar. I'm just going to touch upon the basics so that you get the basic concepts right. Then it will be very easy, to do this testing. Why we are doing this testing, we will be able to understand that. Now coming to the practical aspects of nystagmus, there are why we are trying to do the nystagmus testing is the most common type of nystagmus is peripheral vestibular. So peripheral vestibular, either it could be or it could be originating from the brainstem, or it can be originating because of the cerebellum, or less commonly the supratentorial structures. Okay, so why we are doing this nystagmus testing? We are trying to localize the lesion. Now coming to the nystagmus attributes, like it's very important to understand when we are recording the nystagmus by video nystagmography with the help of video equipment, VNG equipment, we need to understand some terms are very important and crucial. The first thing is we must be able to differentiate between jerk nystagmus and pendular nystagmus. If a nystagmus or if a eye movement abnormality, you can say, or a eye movement finding is having one fast phase and one slow phase, then it is called as jerk nystagmus. So there are three types of jerk nystagmus: with a linear slow phase, then with the exponentially reducing velocity, exponentially increasing velocity slow phase. So there are three types of jerk nystagmus. Then if the movement, like the extraocular eye movement, is showing both the slow phases, it is called as pendular nystagmus. And if there are both the fast phases, there is not a single slow phase, then it is called as nystagmus like movement. It is not nystagmus. Then there are variety of types like macrosaccadic oscillations, like ocular flutter, micro square wave jerk, macro square wave jerk. So these are the types of eye movements which are nystagmus like movements. I'm going to show schematically each and every of these types. So for example, jerk nystagmus. So it begins with a slow phase. This is a slow phase of the nystagmus. And so have you seen the slow component? The slow component was going towards so this is the right and this is left. Okay. And this is right eye. This is the left eye. Now, again you look at this slow phase. It started from here and it is going towards from right, it is going towards the left. Now look at what happens. The slow phase is because it is the genesis of the nystagmus. It is actually the nystagmus begins because of the slow phase. And then the brain realizes that this is abnormal movement and it tries to correct with the frontal eye field area. Just now, have you seen there was a fast component which beat from towards the right side. So in the video nystagmography, graphically it will be recorded like this. This is the fast component and this is the slow. Okay. Then fast component is a corrective component. It is a secondary component, not the primary. But unfortunately, the nystagmus is named after the fast component because it is visible. Why it is named after fast component is because our eyes cannot appreciate the slow component. We will be able to appreciate this fast component. So conventionally, the direction of nystagmus is defined by the direction of the fast component. So now how will the nystagmus will look? Okay. So can you visually appreciate that there is a slow phase from right to left, but there is a fast phase which is beating towards the right side. So the nystagmus is named after the fast component. So this nystagmus is right beating nystagmus, right beating jerk nystagmus, because it has one fast component and one slow component. It's very important to know that, and the graphical representation will be like this. Okay. So the graph will be recorded from like this. So this is a slow component and this is a fast component. This is a slow component of the nystagmus. This is a fast component which is on the graph. And you can see the slow component which is going towards the left and fast component which is beating towards the right. Okay, so I hope everyone is able to appreciate that. Now let us look at the pendular nystagmus. So the slow component from left to right, and graphically it is looking like this, and there is another slow component from right to left. Okay, there is another slow component. So like this, this nystagmus will be seen, like the pendular nystagmus. Now let us look at the difference between what is meant by nystagmus trajectory, what is meant by nystagmus direction. Okay. Now, if you look at this particular nystagmus, try to appreciate what is the, the direction of the nystagmus. The beating of the nystagmus is towards the right side. This is the right side. This is the left side. The nystagmus is beating towards the right. Okay. Now let us look at what is meant by trajectory and what is meant by direction. What is the starting eye position? If you look at the starting eye position of the fast phase, not the slow phase. So the fast phase is supposed from here, the green line, and the ending eye position is here. Okay. So the pathway which is followed, the path taken from the starting eye position to the ending eye position during one half of the cycle of the movement is nothing but the trajectory. So there are three trajectories which are possible. One is horizontal trajectory, second is vertical trajectory, and third is torsional trajectory. Either, okay. So this is trajectory. Now let us look at the direction. Okay. In horizontal trajectory, there are two possibilities. Okay, one is either it can be towards the left side. Now here you can see that is fast phase is towards the left, and the slow phase is towards the right. So this is nothing but the left beating nystagmus. The first one is nothing but the direction is left beating nystagmus, and the lower one, the direction is right beating nystagmus. If you can see, the fast phase is towards the right and the slow phase is towards the left. Okay, so there are two types of horizontal trajectory. One is left beating and one is right beating. Now, on the videonystagmography equipment, how we record this is slow phase towards the right and fast phase towards the left. This is a left beating trajectory. Left beating nystagmus is recorded like this. So you can appreciate in the graphically, the left beating is like this and right beating will be like this. The fast phase towards the right, slow phase towards the left. Fast phase towards the right, slow phase towards the left. Now there are two types of vertical, like two directions of vertical trajectory. The first one is now
Sunday. इधर किधर से आएगा? कहाँ रे?
साइड जाएगा क्या?
यहाँ किधर जाएगा?
भी क्या चल रही ड्राइव भी कर रहे हैं
किधर जाएगा?
वो वाला
then it is fast. Phase is down, and it is a fast phase. Phase up, downbeating nystagmus will be seen like this. And so in upbeating nystagmus, what will happen is the fast phase is up,
साइड से चल
then
सकते
there is a slow phase.
साइड राइड
Fast
से
phase
बढ़िया
is
दिया था
up,
एक दिन, बहुत मस्त
and
दिया
then
था।
the slow phase. This will be seen
दिखाया था
in the
ना
vertical tracing, not in the horizontal. Horizontal tracing will come as flat unless there is oblique nystagmus. If a person has oblique nystagmus, even his trace will show some nystagmusism. If it is a pure vertical, it will clearly show only in the pure in the recording of vertical. If it is a horizontal nystagmus, it will show only in the horizontal tracing. If it is oblique nystagmus, anywhere in between this, then both the graphs will show some movement, like the nystagmus, depending on which side is more. Like, is it more predominantly vertical versus horizontal?
हम तो करें इधर चलो
So similarly, in case of torsional, there are two directions which are possible. Either the upper pole
सैटरडे को फिर
can be
इन्हें थोड़ी जा रहे
towards
खाएंगे
the
बस खा के
right.
आना है।
Okay.
मुझे प्रॉब्लम
From the observer's perspective, if you look at, if you
Looks
are
right
looking
there.
at it now, you are feeling like it is moving like this. Okay. So is this clockwise or anti-clockwise? If it is moving like this, okay, it is moving like this. Sorry, here it should not be like this. It should be moving like this. So it is moving anti-clockwise direction. Now I will tell you what is the fallacy of this particular from the patient perspective. If you are a patient, from the patient perspective, actually this is clockwise for the patient himself or herself. That is the problem with this clockwise and anti-clockwise terminology. That's why Barani Society came up with the consensus that we should avoid the terminology like clockwise and anti-clockwise, and the terminology used should be upper pole of the eye beating towards the right side or towards the left side.
तो पैसा देगा नहीं
Okay, so either it can be a dextrocyclorotatory, that is upper pole beating to the right, or we should mention it as egocyclorotatory, that is upper pole beating to the left. Okay, so these are the two directions which are possible in torsional nystagmus. So there are 3 trajectories and 6 directions. Now there is very important concept of reference frame. Now if we look at the nystagmus, either it can follow eye reference frame or it can follow the head and canal reference frame is same because the canals, semicircular canals are fixed into the head. The semicircular canals are fixed into it, they move along with the head. So both these frames are equal, like semicircular canal frame and the head frame are same. And the earth reference frame, the nystagmus can be even labeled based on earth reference frame in some setting, not in every setting we should label it as in the earth reference frame. So eye reference frames are like there are 3 eye reference frames. If the eyeball there is a vertical axis, anteroposterior axis and a horizontal axis. Then I won't go into the details of that because I will try to keep it as simple as possible. In case of head reference frame, there are planes like this is sagittal plane, this is coronal plane, and this is horizontal plane. And the canal reference frame is similar to the head reference frame, but the canals are not exactly in the plane of sagittal plane. For example, the horizontal canals are not exactly horizontal. It is making an angle of 30 degree. Okay, the anterior end and the posterior end are not exactly
अरे यार
in,
रोड
in
खराब है
one horizontal line. The anterior ends are 30 degree to the horizontal line. It makes an angulation. And the posterior canals are not exactly posterior. They are making an angle of 56 degree with the sagittal plane. And the anterior canals are not exactly anterior. They are making an angle of 41 degree with the
मैंने कम
sagittal
किया
plane.
होगा लगता
Let's look at the gravitational reference frame, that is Earth reference frame. Now, in the Earth reference frame, you can see for all of us, towards the gravity, that is like towards the gravity, towards the center of the Earth, is nothing but geotropic, and if it is away from the gravity, it is apogeotropic. It's very important to avoid the term ageotropic, it is apogeotropic. Now, I will give an example. Suppose this is the head of the patient, this is the bed, patient is lying down, you are looking the patient from the head end, and we turn the patient, suppose, towards the right side. Okay, then this is the right horizontal canal, and this is the ground. Okay, and the eyes will be like this. The left eye is here, right eye is here. Okay, so once again I'll show you. Okay, so patient turns towards the right side.
खुद को नहीं
This is the left eye, this is the right eye, and the patient turns towards the right side. And suppose the patient has this kind of nystagmus. So it is beating towards the ground. It is a right beating nystagmus. The fast phase you can see is towards the right side. In this context, we can call it right beating nystagmus also, but in this position, it is beating towards the ground. That's why it is called as geotropic nystagmus. Here the special
Just to
term
the
Earth
Mara,
reference frame is
just
used, and we call it as a
cold river
geotropic
cold water cold
nystagmus. And if it beats away from the ground, it is called as apogeotropic nystagmus. So the geotropic and apogeotropic term is used specifically in the context of lateral canal BBPV, and sometimes it is used for posterior canal also. There is apogeotropic variety of posterior canal, which I am going to explain in our third session, because that is reserved only for the positional testing, positional maneuvers.
वही ना लाइट
Now let us look at what is meant by straight ahead position, which is also called as
लाइट तो दो
center
किधर
gaze.
भी किधर बैठ
So whenever we are looking straight ahead, that is in the plane, frontal plane. We are in the frontal plane, but in the anteroposterior axis. The eyes are looking forwards. That is nothing but the straight ahead position. Earlier it used to be called as primary position, but Barani Society recommends to use this new terminology, straight ahead position or center gaze position.
इधर भी बहन चोद
Then the next attribute of the nystagmus is whether it is originating. The nystagmus is coming from one eye versus both the eyes. Okay. So if a nystagmus is originating in both the eyes, it is called as binocular nystagmus. If the nystagmus is seen only in one eye, which can happen in case of internuclear ophthalmoplegia, it can happen sometimes in migraine, it can happen in epilepsy, it can happen in glaucoma. So there are certain etiologies where it can happen that there is adduction paresis, adduction is not happening, and there is abduction nystagmus. So in this case, it
Menu.
could be a case of internuclear ophthalmoplegia. So there are a
ये वाला
variety of
देखो।
causes which we are not going to go into
बड़ा
detail,
अच्छा है।
but you should be able to identify that
ये
the
देखो
nystagmus is happening in one eye versus both the eyes. Okay.
खाना हुआ आपका
नहीं मेरा
Then
खाना रात
there is
3 बजे
another
खा के सो
issue
जाएगा।
that is whether
तो
the
रंजन चल
nystagmus
रहा है
is
ना,
conjugate
इसलिए उसी
versus
टाइम खाता है।
disconjugate.
सात
Conjugate
बजे
means
खाते होंगे ना
नहीं,
7:30
it
नहीं,
it
वो
is
खाता है
happening
थोड़ा
equal
फ्रूट
in the same direction and with the same velocity and amplitude, then it is called as conjugate nystagmus. For example, this is a right beating example of right beating nystagmus, and it is happening equal intensity in the both the sides, more or less equal intensity.
सुबह 6 बजे तक खा सकते हैं
वो
It
3
may
बजे
not be
तक
exactly equal
4:35
because
का अंदर
there are two different muscles which are acting. Here there is a lateral
हो
rectus,
गया।
here
और
there is a medial
22
rectus.
नहीं
The
21
nerve
है।
supply is different. The number of fibers, muscle
9 डे हो गया
fibers in that
मेरे
muscle
कुछ
are
दिन।
different. So it may not be exactly equal, but by and large it is in the range of 30% equal, like 30% variation from one to another side. But if there is a different velocity or amplitude of the nystagmus, more than 30%, it is disconjugate.
बोलो ना
The type
चपाती है
the
भैया
type of nystagmus,
चपाती
even though the direction
चपाती
is
फुल्का
same,
कड़क रोटी
okay,
कोलकाता पराठा।
फुल्का भी
but the velocity and
कोलकाता पराठा कैसा
amplitude is
रहता है
different.
कोलकाता
It is
पराठा
called as
खा के देखो
dissociated
अच्छा तो
variety
लगेगा,
of
लेकिन
disconjugate
इनका रेट
nystagmus.
बहुत कॉस्टली है।
कितना है
50
Okay,
रुपीज़
so one eye is moving faster
पराठा।
and one eye is
कोलकाता
moving
पराठा।
slower.
अच्छा
It
फुल्का
is a
फुल्का
dissociated
चपाती सर इधर
nystagmus.
सब कुछ गेहूं का है।
And there
गेहूं
is
का है।
another
गेहूं का
type of disconjugate
बना
which
के
is
भी
called
नहीं
as
रखा।
disjuncting nystagmus.
क्या
That
वेज
is
चाहिए नॉन वेज चाहिए?
one nystagmus is
थोड़ा
beating
स्पाइसी
towards
ज़्यादा
the
चाहिए।
left side and one
चिकन
eye is
कोल्हापुरी
beating
ले लो,
towards the
नहीं
right.
तो
It
चिकन
is a
निमदड़िया।
horizontal variety of
निमदड़िया भी
disjunctive,
अच्छा
that
है।
is convergent divergence nystagmus.
निमदड़िया ये होटल
Then
का
there is a
अलग
vertical
कुछ फेमस है
disjunctive
वो।
nystagmus. It is called as seesaw
इधर का कुक
nystagmus.
का
This is beating up.
पर्सनल है वो।
हाँ
This is beating down. It is called as
एक
seesaw
डिश में सर
nystagmus.
5 पीस आएगा।
And there is a
ठीक
third
है।
variety that
और
is
दो चपाती।
cyclovergent nystagmus. One is beating to
फुल्का है
upper pole
स्नैक्स
beating to
कुछ
the
चाहिए?
left. This side upper pole
ले
is
स्टार्ट
beating
पूछ
to
लो
the
ना
right.
स्टार्टर
Cyclovergent nystagmus. So these are the types of disconjugate disjunctive nystagmus. Now coming to the slow phase velocity, which is a very important parameter. For example, you look at the both the nystagmus and just see what is happening. Both nystagmus are beating towards the right side. Both are beating towards the right. Okay, this is the right side. Can you appreciate that the fast phases are towards the right side in both the cases? But I'm sorry, the lower one, the right-sided eye, this is looking like a monocular nystagmus, but that animation is not working. But this is both sides. Just I assume that this eye is also moving in this slow phase velocity. So if you look at the both the eyes, this eye, this right beating is faster as compared to this right beating nystagmus. So the upper panel is having higher velocity as compared to the lower panel. Okay. So that is the importance of the velocity. So and the slow phase velocity, if it is higher, then the fast phase velocity is is proportionately higher. So that's how these two nystagmus we can differentiate. Then coming to the frequency, how many beats are happening in a second? Okay, that is the frequency in hertz. So if we look at the upper panel versus the lower panel, here the both the eyes are working. It is a binocular nystagmus. If you look at the frequency, it is higher in upper panel as compared to the lower panel. So there is higher frequency in the upper versus the lower frequency in the lower panel.
दर्शन से पूछा दर्शन बोला नहीं जानता हर्षा को
Now
पूछा
coming to
फिर
the amplitude of the nystagmus. Okay. Now look at the nystagmus. This is
बताया
fine nystagmus, which is higher in frequency, but amplitude is short. The amplitude is short.
ज़्यादा औकात है सर
Okay, the frequency is high. The amplitude is short, and that's why it is called as a fine nystagmus, as opposed to look at this nystagmus. The amplitude you look at is bigger. Here the amplitude was smaller. Okay, as compared to this amplitude. Okay, smaller amplitude. This amplitude is larger. Okay, and if you look at the frequency also, the frequency is faster here as compared to the this side. So this is a coarse nystagmus. Okay, this is a fine nystagmus and this is a coarse nystagmus. If you see a patient with, like suppose when the patient looks toward the right side and gets fine nystagmus, and patient looks toward the left side and the same patient gets a coarse nystagmus, then it is called as Brun's nystagmus. Okay, and this is seen in CP angle lesion, and the lesion is on the side of the coarse nystagmus because the vestibular nerve gets damaged here. It leads to the left unilateral vestibulopathy. So the left unilateral vestibulopathy will cause right beating nystagmus, fine nystagmus, which is seen on the right beating. And because of the compression of this tumor over the cerebellum, it leads to the gaze evoked nystagmus, which is a coarse nystagmus. It is beating towards the right side, which is beating towards the left side. So this coarse nystagmus is due to the neural integrator issue. Now coming to the spontaneous nystagmus testing. In the spontaneous nystagmus, what happens is you can either see spontaneous horizontal nystagmus in the center gaze. You have to check in the center gaze. From the center gaze, the nystagmus is beating towards the left side. So it is a left beating nystagmus. So if you look at this nystagmus, this is beating down. It is a spontaneous down beating nystagmus. Why it is called spontaneous? Because it is in the center gaze. Now, if you look at this particular nystagmus, the upper pole is beating towards the right side. So it is a torsional, dextrocyclo, spontaneous, pure torsional nystagmus. Okay. If you see a patient in the center gaze, okay, if the patient has center gaze, this is left beating nystagmus, and the patient either may not have nystagmus on gaze testing, or may be present the same nystagmus, or it can get increased in one direction, or it can get decreased in one direction. So it can, all the variations can happen, and that decides whether it is central or peripheral. So I'm going to come to that. And another peculiarity I will tell you, if suppose a nystagmus has all the three components, suppose a patient nystagmus has a beating component, a beating torsional component, and a beating suppose oblique, like all the three components are there, which is classically seen in peripheral. In this patient, if you ask the patient to fixate, the horizontal component and the vertical component will get suppressed, but the torsional component is very difficult to suppress even with fixation. So it might appear that it is a pure torsional. A peripheral nystagmus can appear as a pure torsional in the center gaze, but it's very important. That's why it is very important to remove the fixation and check the same patient, and then we can appreciate the vertical and horizontal component. So that's why it is so important that we check the patient without fixation. And with the help of video oculography equipment, it is very easy to put the flap and put this that visor, and that helps to block the fixation. So these were the different attributes of nystagmus. Now I'm going to talk about the influencing factors. What can influence the nystagmus? One is gaze position can influence, visual fixation can influence, vergence means convergence can change the nystagmus, and it's very important to identify what pattern of nystagmus a particular patient has. Let us look at the gaze positions, like effect of gaze positions. Now, if the patient is looking straight ahead, this is a center gaze or straight ahead gaze. If the patient looks towards the right, patient can look towards the right,
उल्टा बन चल
or the patient can look towards the left.
देखने दे
Okay, so there are two gaze positions horizontally, either to the right or to the left. Right or left. Now let us look at the recording. This is the object of regard. It is moved towards the left. It stays there, and then it moves towards the right. And you can see in here, it is the eyes are moving to the right, moving to the left, and the visor is open. This flap is open, so it is a test with fixation. It is in light. We are doing it in light. That is with fixation. Okay. So in vertical gaze testing, the same object of regard we have to ask the patient to follow. It will move up. It will move down. It will stay there for the up gaze. It will stay there for the down gaze.
अवनी भी अपने आप में थी मार ली तेज तेज जगह से उधर आ गई थी
It moved up. Now it will go down. And if you look at the eyes, they move up, then it goes down. So the graph also, if you can see it, when the eyes move up, it will go up. Then the stimulus is steady, it stays there, and then it moves down. Either it can come to the center gaze, or it can go towards the left, towards down also. And then like this, the graphical representation of the this particular gaze testing can be recorded. Again, you can see here with fixation. Now, in with fixation, there is no visual cue to the patient. So we have to give auditory cue. Like we have to tell the patient, look towards the right or look towards the left, look up, look down. For the horizontal testing, we have to tell the patient, look to the right, look to the left. For the vertical testing, ask the patient to look up or look down. Now, what is meant by gaze evoke nystagmus? It is a burning question. Like gaze evoke nystagmus is a very hot topic as far as nystagmus is concerned, and it is alarming sign. So now, if you look at this nystagmus, now as conventionally this is right, this is left. Okay. So when the patient is looking towards the left, the nystagmus is beating towards the left. Okay. When the patient is looking towards the right, now what is happening? You see, the nystagmus is beating towards the right. Okay. So look at me now in the video. When I am suppose looking towards the right, it beats towards the right. And if I look towards the left, if it beats towards the left, then it is called as gaze evoke nystagmus. Okay, and that is a central sign. It's a very important central sign. As soon as you see this gaze evoke nystagmus in an acute vestibular syndrome, you should suspect central pathology. Now there are two possibilities. Either in the center gaze, the patient may not have any nystagmus and have gaze evoke nystagmus, or in the center gaze the patient has nystagmus and the patient has in the center gaze, if you see, the patient has left beating. When the patient looks towards the left side, there is a left beating nystagmus. When the patient looks towards the right side, there is a right beating nystagmus. So this is nothing but gaze evoke nystagmus, combination of gaze evoke nystagmus and pure horizontal nystagmus. In such cases, it is very important to check for periodic alternating nystagmus. In these patients, it's very important to check the nystagmus for 90 seconds and check whether the nystagmus is altering its direction after 90 seconds. Now look at this particular nystagmus.
क्या चपाती बराबर हुआ?
In case of peripheral
Rice कुछ चाहिए,
nystagmus,
sir?
in case of vestibular neuritis,
और कुछ चाहिए आपको? इतना ही?
patient suppose looks towards the left side. Suppose there is a left beating
तू
nystagmus,
समझ रहे हो?
and if the patient
भैया?
looks towards the right,
एक
it
चपाती
is
और।
not
One
right
chapati.
beating, it is still remains as left beating, then it is called as unidirectional nystagmus. Despite of the change of the
मैं
gaze,
बोल रहा हूँ
the nystagmus is remaining
कोलकाता
left.
मंगल
The direction is not changing, so it is unidirectional nystagmus, which is classically seen in peripheral etiology. But in case of central, just see what is happening. Look right. When I ask this patient to look to the right, it is a right beating nystagmus. Look left. When I ask the patient to look to left, the patient is
पाजी तो नहीं है।
having left beating nystagmus.
ऐसा होता है जल्दी।
Look up.
ओपन करता है उसी दिन भाग जाता है।
I will play this video again so that you appreciate the gaze yoke nystagmus. Look right. You're seeing double. Look left. So in this patient, when the patient looks to the right, right beating, patient looks to the left, left beating. Of course, there is a down beating component. Keep looking up. So that is typically a gaze evoked nystagmus. It was a patient of cerebellar downbeat nystagmus syndrome, and the patient had cerebellar paraneoplastic pathology.
राजस्थानी सर ने कहा है
Now look at this patient. When the patient is looking towards the right side, there is a right beating nystagmus. Patient looking to the left, there is a left beating nystagmus. Patient looking in the center,
हो गया वेजिटेरियन
there is a pendular variety of nystagmus in the center. When the patient is looking up, it is still beats horizontally. It is beating horizontally even in vertical direction.
आम है ले रहा हूँ।
Even in the down gaze also it is beating horizontally. Okay, so this is a typical case of infantile variety of nystagmus. Okay, congenital nystagmus. Now let us look at the fixation, like methods I use for fixation. VNG, obviously the visor is provided with the VNG equipment to close. Then observing the patient in dark, which like even the patient can't see and we can't see. That's why it's very important to use some method to check this. Pencil glasses is a traditionally used method. M glasses, like Professor microscope glasses, and Rohiwal glasses, like one Indian professor is a neurotologist. He has modified the pencil glasses into type of it can be used for without fixation, like it can be used to remove the fixation.
एक एक सब ले लो
So with the help of the video oculography equipment, this is with fixation, and this we are blocking the
नेक्स्ट टाइम से
vision,
ऐसे करो
and this is
सब एक एक पीस
without
हमको दे दो
fixation.
एक एक प्लेट ले लो उसको
हड्डी देंगे और उसका मेलन
So whenever the nystagmus
फोकट
is present without fixation and it gets suppressed by fixation, then it is usually peripheral. And usually the central nystagmus doesn't get suppressed by fixation. That is central. But the central has liberty of having both the types of nystagmus. In general, central has liberty of having even peripheral signs. So one dictum you always remember, if you see a central sign, it is always central. And if you see a peripheral sign, it can be either central or peripheral. This dictum you just remember, because if you see a central sign like gaze oak nystagmus, it is central. But if you see unidirectional nystagmus, usually it is peripheral, but it can still be central. So that's very important.
तुम्हारा अलग ही एकदम
So, like there another influencing factor is convergence, like which
लगता
you know
क्या
the
कर
infantile variety of
नहीं,
nystagmus gets suppressed by
चलो
convergence.
मार लेंगे अभी जाकर
Then pattern recognition is very important. For example, these are the 9 cardinal gauges,
चखना में रहेगा वो
and in this patient, suppose there is no nystagmus. There is no nystagmus.
क्या
I have just used the schematic diagram. Suppose you get this type of nystagmus in the center gaze, that is upbeating and torsional, upper pole beating to the left side,
नहीं ना
and this is in the
ना तुम बोल दे तो
torsional upbeating in the center gaze.
धन्य
And on one side, if the patient looks, it is more upbeating, and on other side, it is more of a torsional, and it increases in the up gaze. It is typically a peripheral variety, that is posterior canal BPPV, upbeating torsional nystagmus. Then if you see with fixation a patient, and suppose you find this variety of nystagmus, a patient is having left beating nystagmus in the left gaze, left beating in the center gaze, and there is no nystagmus in the right gaze. Suppose this is with fixation, and without fixation, if suppose in the same patient, if you find enhancement without fixation, which is increasing on the left gaze, and it is still there, it is still left beating on the right gaze. So it is unidirectional variety of nystagmus.
तीन
It is following the Alexander's law, so that is, it is a peripheral, typically seen in peripheral unilateral, acute unilateral vestibulotomy. Now, if you find a nystagmus where there is no nystagmus in the center gaze, when the patient looks to the right, there is a right beating nystagmus, and patient looks to the left, there is a left beating. It is a gaze evoked nystagmus. If suppose a patient has horizontal nystagmus in the center, right, left, up, down, it is a infantile variety of nystagmus, congenital nystagmus. If a patient has downbeating in the center and down gaze and side pocket nystagmus in the side gazes, then it is a typically a downbeat nystagmus. It is a central nystagmus. Now the reference frames I have discussed. The central nystagmus follows the eye reference frame. Okay, the peripheral nystagmus follows the head or semicircular canal reference frame.
25.
And for lateral canal and posterior canal, we use the earth reference frame. Of course, in central nystagmus also earth reference frame can be used because there is apogeotropic variety of nystagmus can be seen in some central pathology. It is not restricted to central or peripheral. These are the reference frames. All frames are equally valid. Selection of frame is linked to the mechanism of nystagmus. Specify the frame, and again this is that same infantile variety of nystagmus.
घी लग गया तो 10
So the central nystagmus, remember 3 important features. There is no suppression on fixation. If you see a gaze evoked nystagmus, it is central. If you see a pure variety of spontaneous nystagmus in light, until proved otherwise, it is a central nystagmus. Now let us go to the provocative testing. Like the last another 10 minutes, we will discuss the provocative testing. So there are various provocative testings for the nystagmus, and I have divided them into 3 parts. The one which localizes to the central, one which is, there are 3 which localizes to peripheral, and either it can be central or peripheral. There are provocative testing. So the 2 of the tests are which are very promising is head shaking test and hyperventilation test. Let us discuss. So the one of the very important thing I would like to tell is, if whenever we are doing vestibular testing, it gives findings. We have to interpret the diagnosis based on the clinical scenario. The aim is to estimate the presence of a disorder rather than to verify or quantify it. And the vestibular test battery indicates vestibular test system abnormality rather than the lesion localization. For example, if there is gaze evoked nystagmus versus a unidirectional nystagmus, it will give a abnormality. But lesion localization we have to do based on the other associated finding and the clinical scenario. So head shaking test, what happens? It is a test which screens the vestibular system abnormality by inducing nystagmus through active or passive head shaking. The patient's head is shaken right and left. It is shaken at 2 Hertz frequency. I'm going to show the video. And then we have to check for whether there is any nystagmus which is seen, that is post head shaking nystagmus. Now let us see, he is our audiologist. We can call him vestibuologist because he is now expert in vestibuology also. So he is performing the head shaking test. You can see the head shakes. Okay, after the head shake, he has stabilized the head, and then we watch for the nystagmus. I will play this video again. He's shaking the head at 2 Hertz frequency, that is 2 times in a second. And if you can see, there is a head shaking waves followed by, if there is no nystagmus, it is a straight line. If there is a left beating, there is a left beating, or if there is a right beating, there will be right beating nystagmus. So this is how this or it can be even up beating, down beating nystagmus also. So that is the head shaking test, how it is performed. We shake the head for 20 times, that is 10 seconds. 2 Hertz frequency can be shaken for 10 to 20 seconds, and then you can see the beautiful graph, that is head shaking graph is here, and you can see the horizontal stress here and the vertical stress, and you can see here there is horizontal head shaking, not vertical. So vertically there is little, because exactly we have to maintain the exactly they should be moved in the horizontal position, and then we can see the mean velocity, maximum velocity, and we have to check for the spontaneous nystagmus. Not spontaneous, it is head shaking induced nystagmus. There are certain limitations of head shaking test, but sensitivity is moderate, specificity is also there, relatively high. It has some limitations. Equipment, we can use it with the video occulography, and we have to check for the, basically it is a test to check the vestibular asymmetry. We are checking the vestibular asymmetry by giving the jerks. So now I will tell you very important thing about head shaking. Like suppose like what we have to do while doing the shaking is you little bend the head by 30 degrees so that the horizontal canals become exactly horizontal. When you shake the head towards the right side, the right semicircular canal is activated. When the head is shaken towards the left semicircular canal is activated. Suppose you consider that one movement is a stimulation of 1 plus. So when I move towards the right side, there is a 1 plus stimulation of the right, left side 1 plus, right 1 plus, left 1 plus. So suppose you shake 20 times, there is a 20 plus and 20 plus on right, 20 plus on the left. If both the vestibular systems are functioning equally, there is a no nystagmus. Suppose the right side vestibular system is not working, then you move to the right, 0, move to the left, 1, move to the right, 0, move to the left, another 1. So 20 times you move, it is 20 plus here and 0 here. This 20 plus will get accumulated because of the velocity storage mechanism, and there is a stimulation of the normal side, left side. It will fire, and it will fire, that is slow phase towards the right and fast phase towards the left. So the nystagmus will be towards the left side. That's how
कौन में बिस्मिल्लाह में
paralytic nystagmus
Muslim
will
आई
be
है।
seen, and there are
बस
नाम बोलो जी
varieties of
उसका ना।
nystagmus
बस
in
है
that
मुस्लिम है
biphasic
क्या?
variety,
बहुत से
uniphasic
पूछे।
variety.
हाँ?
बहुत से बीस
So
बस
that
है
is about head shaking
वो
nystagmus.
और कौन
If
है? और ये
you
तो
see
ये भी आया है ना?
vertical
Sir.
nystagmus in a horizontal after horizontal head shaking,
वो तो
it is
लड़का
called
है
as
करने वाला
cross
पानी का
coupled
कैसे को बोलते हैं
nystagmus. It is a sign of central,
सुपरवाइजर है ना वो?
but of course sometimes it
लड़का
can
जो
be
था
even seen in peripheral
Sup-
etiology,
मैं-
but
वो मैडम आया
सुपरवाइजर का
like
देगा पानी
until
देगा
told otherwise it is central.
वर्कर आया है वो।
मतलब
एक
वर्कर
वर्कर है एक मैडम
Coming to the hyperventilation testing, in hyperventilation testing, it is the only test which unmasks the
बिना
vestibular
पता नहीं
deficit without testing dynamic properties of vestibulocular reflex. Means dynamic properties means head shaking we are doing is a dynamic aspect of the vestibulocular
इसके पीछे
reflex.
पीछे भागता है अभी
But hyperventilation
अरे
involves
अच्छा
just
सुनने में
hyperventilation
सुनने
breathing
में आया। और next
to elicit the vestibulocular reflex abnormality.
तुम भी भागेगा
Now look
next
at
month.
this test, how it is conducted. Again, here is our vestibuologist, Mr. Shauka.
इधर ही है
He
ना?
is performing.
दोनों
Now
diagnostic।
the patient is doing the hyperventilation.
अभी देखो कितना में तो केस लोड बढ़ेगा। किम से
Deep
पूरा
breathing
रेफर कर
with
रहा है इधर।
open mouth.
चूतिया टाइप
One
का।
breath
नेक्स्ट
per
मंथ में कोई
second,
है ही
one
नहीं उधर।
inhalation, deep
आयुष का।
inhalation per second, one exhalation 1 second.
खत्म
केस
next
तो
month से
इधर ही भेजेगा
हाँ?
बीच केस तो इधर ही
So
भेजेगा
that this
बोल
is
रहा है
how
जुलाई
it
में
is
चाहिए
performed for
करके सर
60
से
to
बात
70
करेगा जीजा सर
seconds.
से।
That is a
क्योंकि
minute.
जुलाई में उधर कोई भी नहीं है।
And
हाँ बोलो बात करो सब
you
बात
can see
अच्छा नहीं है।
एटेट को बोलो
हाँ।
after the
किसका 2 बार हुआ है उनको नहीं
hyperventilation,
मिलेगा।
we are checking if there is any
बोला
nystagmus. We are checking for the traces
क्या?
after the
पहले
hyperventilation.
उधर एचओडी
Okay.
सर को बोलेगा वो। एचओडी सर जीजो से
So
बात करेगा।
basically, what hyperventilation does is it causes
पैसा लगता है आने जाने का
hypocapnia,
इसको बोलने
alkalosis,
क्या
biochemical
बोलो
changes, neuronal
बहुत खर्च से उधर
hyperexcitability,
फालतू नहीं वही बोल रहा था।
vestibular
अरे वो मैं
system
तो नेक्स्ट
gets
ही मंथ बोल रहा है
stimulated,
तो
central
कोई फ्री
compensation
है तो इधर
mechanism
भेजो
get
करके।
decompensated,
हाँ कोई फ्री है
and that leads to
इंटरेस्ट ज़्यादा है
hyperventilation
तो इधर
induced
चाहिए क्योंकि वो
either paratic
आयुष
or
वाला कोई
excitatory
मतलब
स्क्रीनिंग का
nystagmus.
क्या हुआ
And after
स्क्रीनिंग वो भी कर
the
रहे हैं ये भी कर रहे हैं।
hypocapnia goes away, then again it returns to
तो
normal.
मिलता नहीं है जो
And
स्क्रीनिंग
again,
करने
the
आता है वो
नहीं वो
hyperventilation
पता नहीं
induced
कब करके
nystagmus
जाती है वो
can
मैम
convert to the
वो करके जाती
spontaneous,
है।
either
नहीं क्या
spontaneous
हुआ पता है
nystagmus
वो
or
ना इनके
no
पास डेटा
nystagmus.
मांग रहा था स्क्रीनिंग का।
Then the
तो ये क्या
hyperventilation
बोला
test is
तुम
useful.
आयुष को
It
लेटर
can be
करो
seen in
अगर वो मानता है
22% of
तब
the
तुमको
vestibular
देंगे सब
patient. It
डेटा।
is capable of revealing
तो
latent
उनको भी गुस्सा आया
nystagmus. It can
तो
help
इसलिए
to
वो पूरा जुगाड़
find
लगा
out
दिया।
vestibular neuritis, ostic neuroma, some central vestibular disorders.
तुम्हारा
And there is a very nice study by Professor Luigi,
अच्छा है
where he has came up with an algorithm where if the nystagmus duration is more than 48 hours and the patient has excitatory nystagmus, it is inflammatory in origin, and if it is paratic, consider central. So it is a very nice study. I would request
तो
everyone to
पोस्टिंग
go
अच्छा
through
है
it.
डायग्नोसिस में मैं
It is
थोड़ा
to
बहुत तो इधर
differentiate
उधर
whether
होता
the
है
acute unilateral vasculopathy is
चलना
inflammatory or
पड़ता ना इधर उधर
vascular.
कैफे में कुछ
मैं
भी
तो
नहीं
इधर जाओ फिर
So
से टेस्ट
you
ये
know
करो
these
चलते रहो।
patients with acoustic neuroma shows high incidence of hyperventilation induced nystagmus. Patients with neuritis show high incidence of nystagmus. Vestibular migraine can show like hyperventilation induced nystagmus. Patient with multiple sclerosis can show. Cerebellar disease can show. So if you see a hyperventilation nystagmus, it is not sine and con with central variety. It can be seen in peripheral, it can be seen in central. So it is very important to check whether other signs are there. So none of the findings, they can
इधर ही है
localize.
क्या बीस
You have to consider the clinical context. You have to consider other signs to come to a conclusion. So there are variety of lesions which can show the hyperventilation induced nystagmus. So that is about hyperventilation induced nystagmus, and a short last slide about the peripheral variety of nystagmus. It is the most common variety of nystagmus, and I have chalked down these types of nystagmus. In anterior canal BPPV, there is a downbeating torsional nystagmus. Posterior canal BPPV, upbeating torsional. Lateral canal BPPV, it can be apogeotropic or geotropic. In vestibular neuritis, it is horizontal torsional nystagmus. And in cases of differentiating lesions like specific lesions of some canal, it can show specific variety of nystagmus. So this is our team. He is our audiologist come vestibuologist, Mr. Shoka, our physiotherapy team, dedicated nurse. I'm really